Welcome, everybody, and thank you for joining us this evening for our community talk on living well with celiac disease and gluten intolerance. I'm Samra Blanchard, Division Chief of Pediatric Gastroenterology at University of Maryland. For nearly 20 years, the celiac disease program at University of Maryland Medical Center has been on the forefront of diagnosis and treating celiac disease. The celiac disease program treats both adults and children and is one of the only dedicated celiac and gluten-related disorders practices in the state of Maryland. Tonight, you will learn more about our program, how we help our patients to manage their celiac disease or gluten intolerance and improve their overall health. And now, without further ado, I invite my colleague, Dr. Runa Watkins, up to the podium to start off the night with the discussion of what is celiac disease.
Good evening, everybody. Nice to see everybody. Can you guys hear me pretty well? Okay. So I am talking about the management of celiac disease now and beyond. And just to begin our talk, celiac disease, the definition of it is that we know it's a unique autoimmune condition that has an environmental trigger, which is gluten. And we also know that we make specific antibodies to this. And the main point of celiac disease is that the elimination of this environmental trigger, which is gluten, leads to complete resolution. So there are three categories of how patients usually present with celiac disease. And the first one everyone is familiar with are the classical symptoms, which are your gastrointestinal symptoms of vomiting, diarrhea, abdominal pain, constipation. But then you have individuals who have non-typical or atypical non-GI symptoms. And some of these patients can present with rashes or headaches or brain fog often. And then you have a third unique category where patients are totally asymptomatic but are picked up on screening, whether they have a first-degree family member or they have different conditions that are also associated with celiac disease, and that is why they get screened. So your classical symptoms, which are your GI symptoms, are usually in the pediatric age group. And this is exactly what I had just mentioned. So diarrhea, constipation, vomiting. A lot of these children don't have a very good appetite, they're malnourished, they have failure to thrive or weight loss. And then as we get older, we kind of see the non-GI manifestation. So these are your older pediatric population to the adult world. And a lot of times people present with just iron deficiency anemia. And that's important because iron is absorbed in the small intestine, and which is where celiac disease lives. So that is why patients often present with iron deficiency anemia. Dermatitis herpetiformis is a specific rash. It's actually pathognomonic for celiac disease. So if this is the condition that you have, then it is with celiac disease. A lot of times patients will have erosion of their dental enamel. They can have slight elevations of their liver enzymes. You can have decreased bone density because you are malabsorbing your calcium and vitamin D. And then again, in your older child patients, you will often see short stature or delayed puberty. So the third unique category are those individuals who have no symptoms. And even though they have no symptoms, they'll have positive tests, and they'll also possibly have what we call damaged tissue in the small intestine. And these individuals, I told you, are screened because they usually have a first-degree relative who has been diagnosed with celiac disease. The other special patient populations that we screen are people with Down syndrome and those with type 1 diabetes. There is a category called latent disease where no one will have, well, you will not have symptoms and you will not have any biopsy findings, but you'll have positive blood work. And it is these individuals, given the right circumstances, whether it's time or whatever insult it is, they will develop mucosal damage at some point, and that can be with or without symptoms. So the order of events is usually you have your malabsorption of nutrients. So we talked about iron, but you can also not be absorbing folate, calcium, vitamin D. And the theory behind it is, I know in layman's terms, you've heard of leaky gut syndrome. So that is where you have increased intestinal permeability, and the thought is that these toxins are getting through, and that may be the reason why you are having this autoimmune condition. So the way we diagnose celiac disease is we usually have the blood tests first, serological tests first. And if those tests are positive, then we do recommend a small bowel biopsy through endoscopy. That's still the gold standard for diagnosing celiac disease. And once we have that, if you have complete resolution, which usually occurs within a year on a gluten-free diet, then we've used all those puzzle pieces to confirm that it is truly celiac disease. There are some individuals who may require a little bit more testing besides just serological tests and biopsies. So again, the tests help us identify those who need biopsies. They also help us find those asymptomatic at-risk individuals. They give us evidence for the diagnosis, and most importantly, after diagnosis, they help us monitor whether or not you're compliant with your diet. I'm going to talk a little bit about genetic testing. We offer it. A lot of insurance companies don't pay for it. But we know that in North America, most individuals with celiac disease have the DQ2 gene, and the remaining 5% have the DQ8 gene. It's also important to know that about 20 to 30% of the normal population will carry one of these genes and never get celiac. So we still do not know what the trigger is that causes this gene to turn on. I like genetic testing because it has a high negative predictive value, meaning that if you do not have the gene, it is very unlikely that you will ever develop celiac disease. So after diagnosis, or you've come in to see us with diagnosis, we always get your slides from your biopsies to review with our pathologist to confirm or negate your diagnosis. The other thing that makes us unique is we offer comprehensive nutrition counseling with our dietitian, Pam Cureton, which you'll hear from at the end of the talk. And we not only provide nutrition counseling at time of diagnosis, but also at each subsequent visit. So our timetable for our center is we discuss your pathology results, we provide the nutrition counseling at the time of diagnosis, and 3 months after diagnosis, we provide more nutrition counseling because most patients get overwhelmed with what they can and cannot eat, where they can and cannot go to eat out. At the 3 months after diagnosis, we also address those issues. 6 months and 12 months after diagnosis, we're checking those labs. We're making sure those labs are coming down nicely and normalizing usually within a year. And if those lab values have normalized, we do recommend a repeat upper endoscopy because, again, that is the only way, the gold standard of proving that your small intestine has healed. There are nutrition labs that also need to be done on a yearly basis after you've been diagnosed, and we check your iron, your hemoglobin, your ferritin, your vitamins of B12, zinc, and folate, as well as vitamin D and calcium. And a few studies one study that I also get is a baseline bone density scan because you can have decreased bone density from not absorbing your calcium or vitamin D. And I discussed the repeat endoscopy after a year of being diagnosed. These are some potential nutritional complications with untreated celiac disease, which we talked about. And then major complications, again, short stature, dental enamel hypoplasia. In the adult world, you worry about infertility and osteoporosis. You can have neurological disturbances and ataxia that has been reported by some patients. And years of not adhering to a gluten-free diet can lead to intestinal lymphoma. It's not very common, but it is a risk. So the only treatment for celiac disease right now is a strict, lifelong gluten-free diet. And then Pam will talk to you more about what you're avoiding, not only wheat, barley, or rye, but she'll just get into more depth. Main asset to our program is Pam Cureton, and you are able to meet with her at each visit. Thank you.
So we are continuing our presentations back to back, so this way we can allow a lot of time to have your questions and answer session. So what I will be covering now is the non-celiac gluten sensitivity. So when we expose to gluten, if you have a reaction, there will be actually four reactions. One, nothing, that you do well and you tolerate okay. And you may develop immunologic reaction and have celiac disease, as Dr. Watkins explained. Or you may have wheat allergy, if it's same as like milk allergy, soy allergy, peanut allergies. And allergies can be two types. Like one is you develop hives, breathing difficulty, eczema, respiratory symptoms. So these are rapid onset allergic reactions, and we call them IgE mediated. It is very similar like if you have any other milk allergy, soy allergy, any other food protein allergies. Then there is non-IgE mediated group, which is you still have allergies, but you don't have these acute symptoms. But when we do endoscopy in the GI tract, we may see eosinophils, which are the typical cells for allergic manifestation. And when you see the eosinophilic cells above certain number, you're suspicious of either eosinophilic esophagitis or eosinophilic gastroenteritis. These are all grouped under wheat allergy. I don't want to give you a misunderstanding that when we scope and we see allergy cells, we don't know what you're allergic to. So we still send you to allergists to have either skin testing or blood work to look for acute reactions, or patch testing to look for these delayed reactions. And if you do not have celiac disease, if you do not have wheat allergy, but you just eat a slice of bread and you're feeling miserable, then you have gluten sensitivity, which I will be focusing on my talk today. So non-celiac gluten sensitivity is unable to tolerate gluten and develop an adverse reaction when eating gluten. This could be abdominal pain, this could be fatigue, this could be diarrhea, or feeling miserable, not able to sleep, which we will go into the symptoms. And some symptoms may resemble celiac disease too, but the key part is there's a negative celiac serology, we rule out the wheat allergy, and there's no small intestinal damage, meaning that you have normal small bowel under the microscope. Currently, the diagnosis is made by exclusion and an elimination diet and open challenge. So basically, if you're telling me that you have gluten sensitivity, I will tell you that, okay, let's withdraw the gluten from your diet, give 3 months, and reintroduce it. Within the reintroduction, if you have symptoms, then you have the diagnosis of the gluten sensitivity. So let's review a few facts about the non-celiac gluten sensitivity. The lack of clear diagnostic markers and criteria may have led non-celiac gluten sensitivity underdiagnosed by physicians for many years. The prevalence of non-celiac gluten sensitivity is estimated to be between 3% to 6%. And the research estimates that 18 million Americans have non-celiac gluten sensitivity. And the genetic component of non-celiac gluten sensitivity is not yet completely understood. Only 50% of gluten-sensitive patients express HLA-DQ2 or HLA-DQ8, indicating that these genes are not necessary to develop gluten sensitivity. So let's look at the pathogenesis. I mean, it's unfortunately unclear. There's possible speculations. One speculation is that there's an increased permeability of the small intestine, or there might be a gluten-induced low-grade inflammation that we're not able to see under the microscope, but there's a minimal inflammation is going on. There's an opioid-like activity of the gluten, which I would like to describe a little bit. All of us has like morphine-like receptors in our body. And gluten in some patients can act like opioid, which means morphine-like receptors. So gluten can affect those receptors, and you may have this fatigue or brain fog, this type of symptoms that some people come to our clinic and complain about. The other speculation is that it may affect the innate immune reaction to non-gluten components of wheat. So celiac disease requires a more adaptive immune system, and then this one is the initial immune system. But again, we do not have any evidence to prove that. And the last or not least, but the placebo effect of gluten withdrawal and challenge. If you think about it, any drug may have effect of 40% improvement as a placebo effect, and that's a large number. So again, if you're feeling or having a symptoms, going into gluten-free diet makes you feel good. Even if it's a placebo effect, I'll take it. I mean, research studies show that even the drugs have the placebo effect too. So I don't want you to think that, oh, I'm not faking it. It's not that. You're feeling better actually on the gluten-free diet, whether it's a placebo effect. So let's review the symptoms. It can vary from abdominal pain, bloating, flatulence, like irritable bowel symptoms symptoms to eczema, rash, headaches, foggy mind, fatigue, diarrhea, depression, anxiety, joint pain, numbness and tingling in legs, arms, or fingers. I mean, you can have many variety of symptoms. What I would like to focus on, two things in a little bit more detail, is irritable bowel syndrome and gluten sensitivity, and autism and gluten sensitivity. So there's a complex relationship between irritable bowel syndrome and the diet. Gluten ingestion may elicit GI symptoms in patients with irritable bowel syndrome diarrhea group. So there's irritable bowel syndrome divided either constipation or diarrhea, and we know that the gluten may produce symptoms in the patients with the more IBS diarrhea group than IBS constipation. So gluten alters bowel barrier functions in patients with IBS diarrhea group, particularly if they have positive HLA-DQ2 or DQ8. In this subgroup, the gluten elimination may improve patient symptoms in irritable bowel syndrome. Besides gluten, other wheat derivatives could play a role in causing symptoms in irritable bowel syndrome, like amylase trypsin inhibitors and fructans. So these are the part of the wheat when we ingest. So not necessarily the patients may be reacting to only wheat, but they might be acting against these substances. Also, as I said, that I would like to talk about autism and the relation of the non-celiac gluten sensitivity. So if you look at the meta-analysis and larger studies, there's no association between celiac disease and autism. It has been hypothesized that some symptoms may be caused by opioid peptides from the incomplete breakdown of gluten and casein. Again, we speculate leaky gut syndrome, but it is still a major debate in medicine. So when we look at evidence-based medicine, you have larger studies when they are double-blind randomized, and then there are case reports. So when you look at the case reports, that 3 patients in one practice may report that their symptoms got better after being on gluten-free, I suggest then that's great. But if you look at the larger studies, that there's no difference between using this diet and treatment of autism. But usually when the patients come to my practice, I suggest that let's try gluten-free and casein-free diet for 3 months. If you see a benefit, we'll stick to it. And if you don't see a benefit, then we can go back to the regular diet. So we still need additional research to understand the connection between autism and non-celiac gluten sensitivity. So if we look at non-celiac gluten sensitivity, does not have strong hereditary basis like celiac disease. It's not associated with malabsorption or nutritional deficiencies, and not associated with any risk of autoimmune disorder or intestinal malignancy like in celiac disease. So one thing I want you to really take home from today's lecture is that please do not self-treat yourself. This is what we're seeing in our practice. I have patients come in and saying that I'm already on gluten-free diet, feeling much better than before. Can I just assume I have gluten sensitivity? The consequence of that self-treatment is a missed celiac disease. So if you're having symptoms and thinking of going to gluten-free diet, please contact your primary care or contact us. Then we do the appropriate testing and checking your serology. If your serology is negative, then we can say that we can put you on the gluten-free diet, and knowing that you have gluten sensitivity. But you need to be really evaluated first, because missed celiac disease has consequences, as Dr. Watkins mentioned. So if you're exposed to gluten, you become miserable with gluten sensitivity. But in patients with celiac disease, if you have intermittent, unintentional exposure, you're still, at risk of the complications. So it is a really important difference between the gluten sensitivity and celiac disease. Then now I will turn it on to our research coordinator, Elaine Pupa, to tell about what is new in celiac disease.
My name is Elaine. I am a nurse. I also have a PhD, and I help the physicians with their research. I help the doctors with their research, and I'm going to talk to you about what some of the new treatments are for celiac disease, or what we hope some treatments will be, because we're not really at the treatment stage yet other than the gluten-free diet. So the first thing I want to talk to you about is serologic testing. Those are the blood tests that we do. There are several different types of blood tests that we currently use, and if you go to one lab, you'll get one blood test, and another lab, you'll get another blood test. So one of the things that's going on in Israel right now is they're doing a very large-scale study of all of the different blood tests and running all of the different blood tests on the same person at the same time. So hopefully when that test ends in another year, we will better be able to look at the blood tests and say apples are apples or apples are oranges. We're not, but right now if you go to this lab and you come back with an abnormal value of 7, you might go to that lab and come back with an abnormal value, but the cutoff is 20. So that's one of the pieces of research that's going on right now. There is research going on in the concept of finger prick tests. This is particularly going on in Europe. It's not made it to this country yet, where you can do a quick test at a primary care physician, or in Britain they're actually testing it at pharmacies, where it's just a blood test. They prick your finger like you do for diabetes, and then 10 minutes later they can tell you if you have certain of the antibodies. It's not diagnostic, but it does function as a screening test, and they hope it will be useful for that large portion of people who have celiac disease that don't know they have celiac disease. Another test that's not a blood test now, but a urine test that's just been published, the research is just published this past week, is a urine test where they can test to see if you're cheating. And so what that will do is they'll collect the urine, and what they can actually do is look for the gliadin peptides in your urine by this particular test. It takes a couple days to run. And then they'll be able to know how compliant you are with your diet. So I'm just giving you a word of warning now. Italy is also doing some stuff with antibody cultures, which, as both of our doctors explained, that's one of the ways we test. We look for the part of your body that says, oh, this isn't supposed to be here. And for those people who are gene positive and have some labs positive and some labs negative, that's a real conundrum for us. We don't know what to do with that. And Italy is actually doing some things where they actually take, when they do the biopsy, a little piece of tissue from your intestine and grow that in culture, and then test it with some gluten there. And they're finding better results by doing it in culture that way. So that's another thing that's down the road for all of those people who fit in the gap where we don't have clear results. There are some tests going on for gut permeability. One of the really cool ones for that is that when they do the endoscopy, there's going to actually be a chemical probe that they can put down through the scope and then use electron microscopy and look and see the gut's reaction. So I think that's like a really cool and exciting thing. So far, as everyone has said, we're not doing so well with the markers for gluten sensitivity. There are a couple of markers on the actual gluten, a different part of the wheat that that seem to be markers for potential gluten sensitivity, but those haven't really played out in the research yet. They're very preliminary and just in lab stages. So I'll talk to you a little bit about treatment. The drug that is the furthest along in the treatment pipeline right now is called lorazepam, and that one actually is beginning phase 3 trials, which are the large-scale trials in clinical trials, different areas of the country. That's not going to cure celiac disease. It'll be like a lactate pill that you take that will help treat your symptoms when you have an accidental exposure. Alvine 003 was a big drug about 2 or 3 years ago. That company has been bought. The drug has essentially been tabled. It's no longer in the pipeline. The results were not as promising as they had initially hoped. There is a new one. Again, this literature is hot off the presses in the last couple of weeks. Something called IgY, which is being tested in Italy. They're looking at it. They actually grow antibodies for the gluten in an egg yolk type system. That's why the Y. And it appears that perhaps the gluten will adhere to that protein and your body won't be recognizing it as a foreign entity. So that's in very preliminary stages. 10 patients have been given that drug and it's proven safe. They have not started effectiveness studies yet. There is a vaccine in the works, which will be a little like a micro patch thing that they're looking at. That again has only been done in a few people. The current regimen is like 2 shots a week, and it's in very preliminary tests. AMG 714, I'm sorry these all have ugly names and not cute names, but AMG 714 is all we've got, is an antibody that's looking promising for treating refractory celiac disease for people for whom the gluten-free diet is not effective, that puts them at significant risk for a lot of other complications. And then we have pancreatic enzyme treatments. I wanted to say a word about those. Those are things like ANPEP or glutenase. Those don't work for celiac disease, period, the end. So when you see all these literature things on the web that say, oh, you can take this and tolerate gluten, if you have true celiac disease, that's not an option. They may work for gluten sensitivity, so that may be an option there. Hookworms, that's my favorite one because everybody always goes, ooh. That's a big deal in Australia. That initially was very effective in treating symptoms, but when they actually do the biopsy for damage, it's not proving effective. So we're over hookworms. You don't have to eat hookworms. FODMAP, as the doctors mentioned, is also another treatment that is proving somewhat effective for people who have symptoms even when they're on a gluten-free diet. That one still needs a lot of research. So the other thing that they're looking at is gluten modifications. This one's fun too. Microwaved wet wheat. Anybody heard of that one? I'm just curious. There was a study that looked at, the theory is that if you can microwave it and break down the gliadin, then in theory it would not prompt symptoms. So microwaved wet wheat, you soak the wheat, you put it in a microwave. By some measures, it was not producing the gliadin peptides that are the ones that cause problems for people with celiac disease. But when they did further analysis and did the testing a different way, they found that the peptide was still present and it could still cause symptoms. So that one's off the list. Enzyme treatments. There are 2 different enzyme treatments that they're looking at right now. One is being done by using bacteria like they use for sourdough bread that's known to help break down the gluten. And that's showing some effectiveness. We're not at commercial stage or close to commercial stage for that. And then a study that came out in the last 2 weeks is looking at Saccharomyces, which is a fungus, again, similar to what grows in what you would use for sourdough bread. It's also what they use for Florastor, which you sometimes see used in pediatrics when somebody's getting antibiotics. And that has shown some promise in blocking the antigens that tend to open the gut and allow the gluten in. Again, very preliminary. Don't go out and buy Florastor and think you can go eat a loaf of Italian bread. So the next thing I wanted to talk about is all of the tests that are on the market that allow you to come out and eat a meal like this without having it labeled gluten-free in advance. There are 3 major tests being marketed on the market right now. NEMA is the first one. That's the little black triangle you see on the screen. That costs about $300 for the equipment, $279. It includes 3 little disposable capsules. It takes about 3 minutes. You take a little scoop of your food, put it in the little thing, shake it up, let it sit for a few minutes, and then you get a readout of whether or not there is potential gluten in your food. The biggest problem with that is that if you get this piece of food and it's not cross-contaminated and you get that piece of food, you don't really have an accurate readout. But that is out there. The replacement capsules cost about $5 to $6 each. So if you're going on a long trip, that's not a really feasible option. But it is out there if you're like going to a friend's house. Also, one of the concerns is if you're like going to your in-laws' house and you whip out your gluten thing because you don't trust your mother-in-law, that may not work well either. Easy gluten is another one. It's much less expensive. It's two capsules for $25. The problem with that one is it takes about 25 minutes. So I'm not really sure who's going to set the little thing on there, and it's got like multiple steps. So about, you've got to sit there with your test tube and measure it and mix it and then move it over into the next test tube and shake it up and let it sit. That's not really feasible for sitting at the restaurant with your in-laws or your fiance or something like that. Gluten tox is very similar. It takes, again, about 20 to 25 minutes, and it's 2 kits for $32. But if you're interested, they have information about them on the web for anybody who wants to look it up. Then I'll talk a little bit about our research. The most recent published research we have is the one that Dr. Watkins worked on, that's tissue transglutaminase levels are not sufficient to diagnose celiac disease. This was a multi-center study that was about 4 different sites in North America that reviewed all of our records and looked at all of the people who we had diagnosed with celiac disease and what their lab values were and what their biopsies were and things like that. And we get a lot of patients come to us who have been diagnosed with celiac disease just by lab values. This study showed that that's not an effective way to diagnose celiac disease, that you really need to do the biopsies, that just lab values are not going to tell you the true story. We have another one that's not published yet about arsenic levels in celiac disease. There has been, in the last 1.5 to 2 years, a lot of concern about arsenic levels, particularly in rice. And since people with celiac disease eat a lot of rice, that's been a concern. None of our patients that were tested, and it was over 50 patients, had positive arsenic levels in their blood. That's contrary to an article that was just published that showed that people did have elevated levels of arsenic in their urine. I don't know what we're supposed to do with that. I guess that means we just need to do some more testing. We have ongoing research. We have a celiac disease registry. We have over 1,500 people in that registry right now. That includes people with celiac disease and gluten sensitivity and family members of people with celiac disease. We have a study, a study going on with HLA and genotype and age of celiac disease diagnosis. There is some evidence in the literature that people with different sets of genes, as we talked about DQ2 versus DQ8, and how many copies of those you have, cause you to develop different symptoms and may cause you to develop celiac disease at different points in your lifetime. So that's an ongoing research study that we have now. We also have a study where we're looking at anxiety and depression in celiac disease. And if anyone is interested, I can email the references for some of these things to you, and my contact information will be available. I thank you for your attention, and now I'd like to introduce our dietitian extraordinaire, Pam Cureton, who has 22 years of experience in this field. Thanks.
I did start this when I was 12, by the way, just because you're all going, oh my gosh, you can't be doing this for 22 years. It's like, yeah. So if you don't mind, how many of you have celiac disease? Please stretch and hold your hands up really hard. How many of you do not have celiac disease but know somebody who has celiac disease? And how many of you are just here for a free meal? Okay, that has nothing to do with my talk, but I thought you needed a chance to stretch a little bit. So feel free to move around a little bit. So once I figure out how to move this, thank you, move on. So again, I always start every single talk I do with this slide. Please do not start the diet until you've been properly diagnosed, as we see this frequently in our clinic. So people come to us already on the gluten-free diet and want to know if they have celiac disease, non-gluten sensitivity, if they're crazy, what's going on. So I really need you to be sure you get your testing completed, because your treatment can differ depending on your diagnosis. Now, for example, this young lady just thought she had gluten intolerance or perhaps gluten sensitivity or maybe celiac disease. So she's like, well, I'm just going to stop eating wheat. And when the pain and symptom got to be too much, she ran to the hospital and voila, she had a baby. So I'm just saying, be careful. You may think it's wheat intolerance and okay, get the nursery ready. So it is important to know what you have and get the right diagnosis. We talked about celiac disease, we talk about non-celiac gluten sensitivity. And again, a lot of people will say, well, what's the difference? The treatment is the same. So whether I have celiac disease or gluten sensitivity, I'm still going to have to follow the gluten-free diet. Well, there are some differences to point out. Yes, the same treatment is the gluten-free diet. However, how strict do you have to be? I know how strict you have to be if you have celiac disease, but maybe if you have non-celiac gluten sensitivity, you might not have to be as strict as you would if you had celiac disease, because basically I'm going to keep you as strict as I need to be to resolve your symptoms. So maybe you don't have to worry about if those French fries are in a dedicated fryer, and maybe you can sneak the filling out of a cheesecake. So some of those things you may be able to get away with celiac disease, absolutely not. We know that celiac disease is lifelong. It's an autoimmune disease. You're going to have it for the rest of your life. Again, that's why the importance of getting diagnosed, because you're going to be diagnosed with something you'll have forever. Non-celiac gluten sensitivity, we don't know. We haven't really studied this long enough to know. You may have a gluten intolerance now, but you may not 5 years from now. So it's good to know what that difference is. So we know that on both, you will improve on a gluten-free diet, your symptoms will improve. But what about non-compliance? So we know that physical symptoms will occur with both, and again, as you've heard, those symptoms are very similar. So the symptoms of celiac disease and non-celiac gluten sensitivity are very similar. Celiac disease, you're actually causing intestinal damage. So you're actually going to be destroying the villi in your stomach when you cheat or you're not on a well-controlled diet. With the sensitivity, there is no damage to the gut. You'll suffer the symptoms, but you won't suffer any intestinal damage. Again, I will repeat, there is good biomarkers for celiac disease. We know how to test you for celiac disease. There is not such a test for sensitivity. Again, unfortunately, a lot of people come to us with these tests from other labs and show us and say, I've been diagnosed with gluten sensitivity through these labs. Those are not accurate labs. They're not validated labs. So I often tell people, if you want to spend $500, come to me, I'll spin the wheel, and then I'll tell you whether you have sensitivity or not. Same thing, only I could use the $500 more than they can. So again, there's no biomarker for gluten sensitivity. Comorbidities, we know very much so with celiac disease. So we need to test you for those. We need to keep track of your lab work. We need to have additional testing, such as a DEXA and your bone density. So there's other things that we need to test with celiac disease. Sensitivity, we just don't know. We don't know if there's other comorbidities. So we need to follow you carefully for that. So again, following the gluten-free diet, this is pretty simple, pretty straightforward. We know that the grains that contain the gluten that you have to avoid are wheat, rye, and barley. In addition to the wheat, rye, and barley, from barley comes barley malt and brewer's yeast, or other things that we need to be careful of. And this is something I always go over with when people come to see me. Usually it's the first place I start. Most people are very confused about how to read a food label and to know whether or not a product is safe to eat. So if it says gluten-free, then you can have some confidence knowing that the product is indeed gluten-free. But what if it's not? So what if the expensive name brand product is labeled gluten-free, but the store brand is on sale and you have a coupon? So do you have to buy the expensive one, or is the cheap one okay too? So there's only 6 little words that you need to know when you check the label. You don't need to know all those fancy words or big long things that are chemicals that we never heard of and can't pronounce. You just need to know 6 simple words. You need to know wheat, because wheat is actually covered under the Food Allergy Labeling Consumer Protection Act, which says if any of the top 8 allergens are used in any way, shape, or form, they have to be listed in plain English on that label. So modified food starch, dextrin, seasoning, any of those other caramel color, any of those other nebulous ingredients that we always had to worry about. If they came from wheat, had wheat, it would say wheat in parentheses next to it or under that contains statement, capital C, contains. If there's a contains statement, wheat's in there, it'll say wheat. So you no longer have to worry about the products having hidden wheat sources. Now, wheat is the only one that's covered under that rule. The barley and the rye are not. But they're not hidden ingredients either. They're going to be listed on the food label as barley or as rye. They're going to be there on the label. And again, from barley come the two ingredients we need to look out for: malt flavoring, malt syrup, malt extract, not maltodextrin, isomalt maltase. So if it sounds like a chemical, it's fine. If it sounds like a food, don't eat it. So again, look for those words of malt flavoring, malt syrup. Brewer's yeast can be a byproduct of beer production. And last, if it's not labeled gluten-free, you always want to stay away from an oat product not labeled gluten-free, because those oats could be highly contaminated with wheat. So you only want to have oats that are gluten-free. So you have been following your gluten-free diet. You've got the right diagnosis. You know you're not having a baby. You know it's celiac disease, but you're still not feeling better. So what's going on? You're supposed to feel better in a couple weeks, but you're still having all these other symptoms. So again, we need to take a look at what are some of the other reasons that you may not feel well. One of the big ones is a lactose intolerance. Lactase is produced at the very tip of your villi. When you have damage, you're going to lose some of that enzyme you need to break down the sugar in milk. So for temporary purposes, you may not be able to tolerate milk. So you may be able to tolerate a yogurt, and you may be able to tolerate a piece of cheese, but you can't tolerate yogurt, cheese, and a glass of milk. Then you start to have gas, bloating, diarrhea. May confuse that to having a gluten exposure. So again, take a look, and we can test for lactose intolerance, but you may also want to reevaluate your diet as to how much lactose you take in at one time. Also, constipation can cause these symptoms. When we make a change in the diet, so if you're used to eating high fiber wheat, whole grain wheat and whole grain pastas and whole grain cereals, and you switch to lower fiber foods, constipation may become an issue. And again, constipation can present with gas, bloating, cramping, some of those unpleasant GI symptoms. So be sure that you're getting enough fiber in your diet as well. So when we have a problem with not healing or feeling well, you're compliant with the diet, you think you're doing everything right, but it is rather common that people do have these persistent conditions. But most of these conditions can come down to simply you're continuing to get a gluten exposure. So the vast majority is gluten is getting into your diet in some way, shape, or form. That's why you need to come to a team like this that we can examine the diet, but we can also take a look at other causes. What else is going on? Is your celiac disease well controlled? As Dr. Watkins has pointed out, we go through testing. We make sure we get those antibodies back to normal. Are you back to normal? Has your gut healed? Is it your celiac disease? Or do we need to look at any one of these other conditions that may be causing your symptoms? So we need to know what we're dealing with. Like I said, though, the great majority is actually gluten exposure. You're still getting gluten in the diet. Unfortunately, some people don't have the benefit of having a good diet instruction. So they may miss some of the finer pieces of how to avoid contamination, what they need to do, not sharing toasters, again, not double dipping or making sure those French fries aren't in a same oil that they're doing all the other breaded products in. So are you eating, when you're eating in a restaurant, are you following the right rules and asking the right questions? So are you being careful about the sources? Are you reading those labels? So sometimes we have to really dig deep to find out where this gluten exposure is coming from. We also, though, have developed a treatment plan for people who have been diagnosed with celiac disease, have been very careful about their diet for the last year or more. they have been very compliant. They sit down with me, I scrutinize them, I shine the light in their face, and I said, where have you been getting your gluten? And I can't come up with anything. But their symptoms continue, damage continues, or their TTG is still elevated. So we have to do something to help treat them. There are some powerful drugs with some very bad side effects that we could use, but what we've found to be successful is to eliminate any source of gluten contamination from the diet. We've actually developed, the fancy term is the gluten elimination contamination diet, because that sounds good, you know. So we have a plan to help treat you and follow you with through the diet. So we've actually been very successful at treating people who have not been able to bring their numbers down, to get their disease under control by making those modifications in the diet. So it typically is a short-term, it's a short-term duration special diet developed just for that. Again, it eliminates any source of gluten contamination that may be coming into the diet. We have published a study. We've taken a look at the results with the diet. We have published on a diet, and we have found it to be quite successful. So rarely do we find that this is the case, but we also know how to treat it. So we have treatment plans for the difficult group that may have difficult coming under control. There is another type of non-responsive, which is refractory, we've mentioned a little bit about, which unfortunately is one of the most severe cases of celiac disease that doesn't respond to diet at all. But again, we are well aware, we know the difference, and we know how to treat those types of difficult cases, because this is what we see and treat at our clinic.